Well, hello and good evening, everyone. Welcome to the DYSIS Smart Colposcopy webinar, where we'll take a deep dive into the publication, Increased Detection of Precancerous Cervical Lesions with Adjunctive Dynamic Spectral Imaging. My name is Brent Palmisano. I'm with DYSIS Medical, and I have the great privilege to introduce the speaker this evening and the author of the paper, Dr. Sara DeNardis. Dr. DeNardis is a gynecologic oncologist with Kissimmee Women's Health Center in Central Florida. She's board certified by the American Osteopathic Board of OBGYN and also board certified in GYN oncology. Dr. DeNardis attended medical school at Des Moines University, and she completed her residency at Mount Clemens General Hospital in Michigan. She completed her gynecological oncology fellowship at Florida Hospital Orlando Cancer Institute. Now, throughout the webinar, you'll also hear references to DYSIS Smart Colposcopy. So let me quickly explain that DYSIS is a next-generation digital video colposcope, and it has an advanced cervical imaging technology, and it essentially standardizes every aspect of aceto-whitening. And it does that through assessing the aceto-whitening intensity and duration and generating an adjunctive color-coded map that quantifies that process. DYSIS also has a medical-grade computer, an imaging or head or camera, and integrated acetic acid application that applies 1.5 cc's homogeneously on the cervix. It also comes with a touchscreen interface, so all aspects are essentially standardized of the colposcopic exam. And so with that, it is great pleasure that I hand the next 20 to 30 minutes or so over to Dr. DeNardis, who will take you through this wonderful publication. So Dr. DeNardis, off to you.
Thanks, Brent. I appreciate you inviting me to speak today regarding the results of my study. We're going to talk about the IMPROVE-COLPO study in general, and then also my data from the overall study. So we're going to go through the study objective and design, and we'll talk about the patient demographics and data, and then we'll talk about the actual results and how this may benefit our patients in the future, with a little bit of time for questions at the end. So the IMPROVE-COLPO study, the objective of it was to look at real-world colposcopy, so what happens in general practice, and then to compare it to what happens when we add the DYSIS mapping system onto that. It was all study candidates were in the United States, and then they were in community clinics, and we wanted to compare this to standard colposcopy and standard of care practice. The study was IRB approved. It was observational. The patients received standard of care, and there was really no additional intervention except for adding on the DYSIS map. It was a cross-sectional study. The patients were seen one time only with no follow-up besides pathology from their biopsies that day. And there were two arms to the IMPROVE-COLPO study. The overall study had a control group, and these patients were retrospective by the same colposcopists who were examining the prospective patients. And the retrospective patients were accrued by going back in our records from the day that we started DYSIS backward, so that we could get the patient's data from when we had no DYSIS map and compare it to see previous results to future results utilizing the map. The study group then contained the patients moving forward from the day we started using the DYSIS map, which included extra biopsies at the discretion of the colposcopist. We never took biopsies away, but we potentially added biopsies based on the mapping results. And then each colposcopist had the same number of patients in each arm so that we could reduce any bias. So the intended use for the DYSIS arm only, so this represents my portion of the study. The patients were utilized as their own control. So they all got standard of care colposcopy. We were utilizing the DYSIS colposcope, but it does basic colposcopy as well. And then we would give our colposcopic impression, either normal, low grade, or high grade. And based on the impression and our experience, we would recommend biopsy at certain sites, and we would record those on the machine. After we did our basic colposcopy, we would add on the DYSIS map. Usually it takes about 2 minutes to get this map. And this was used as an adjunct to our previous colposcopy. And based on the mapping, we would decide, do we want to add any additional biopsies? And we would record that as well, which were recorded as DYSIS biopsies. The biopsies, of course, were sent to pathology, and results were obtained so that we could find meaningful data on our patients. So the overall study view of the IMPROVE-COLPO study, both retrospective and prospective, was from 45 community-based clinics. These could be single or multiple physician clinics. They could be private offices, hospital-owned clinics, teaching hospitals. Overall, there were 159 different colposcopists, including GYN oncologists, general OBGYNs, nurse practitioners, and physician's assistants, all experienced in colposcopy. And there were over 7,500 patients that were in both arms, both the pre-DYSIS and post-DYSIS arms. The population was, of course, women equal to or greater than 21 years old who had a PAP and HPV that would push them to colposcopy based on standard of care recommendations. Patients that were pregnant or had a previous hysterectomy, if they had HIV or AIDS or had received radiation or chemotherapy for a pelvic cancer were excluded from our study group. And then the biopsies that were obtained were either labeled standard for the patients who received colposcopy prior to the map being added on, or random. The guidelines would recommend that we can increase detection by adding random biopsies, and so some random biopsies were obtained by colposcopists, or DSI biopsies, which were obtained after the DYSIS map was added in, and we deemed it necessary to add additional biopsies based on the mapping. So, of course, for the outcome measures, we want to see how many cases of high-grade dysplasia were detected. So detection rate, the percentage of patients that had CIN2+, among all the patients, the number of patients that were biopsied was obtained, the number of biopsies that were taken, and then what's the positive predictive value of these biopsies? How useful are they to our patients? The analysis was a cohort comparison, the incremental benefit analysis as well. And then we looked at different subgroups, different age groups, different races, as well as different histology and different qualifications for being referred in the first place, as well as the types of biopsies. Was it a standard biopsy? Was it a random biopsy? Or was it a DSI biopsy? So the study patients, and this is referring to the whole overall study. So for my portion of the data, we had the DYSIS arm only patients, and they were consecutive colposcopy referrals, eligible for colposcopy, again, based on standard of care guidelines, and they were examined with the DYSIS map as well as routine colposcopy. The control arm of patients, again, were consecutive prior to utilizing the DYSIS map, but by the same provider. So on Tuesday, I did a colposcopy without using the map. On Wednesday, I started using the map, so my prospective versus my previous patients. The data was selected based on billing and appointment records to go backwards and figure out the consecutive patients from the day of starting DYSIS. All clinical procedures and patient management were standard of care because everyone received standard colposcopy, and then the study arm received DYSIS as well. The different analysis focused on the patient subgroups and then different aspects of the study, so we could look at low grade versus high grade and so on. So I think the bottom of this slide is cut off, but Dr. Warner Huh, who's the immediate past president of the SGO, looked at the retrospective data from the IMPROVE-COLPO study so that we could kind of come up with what is the baseline for colposcopy in the United States. So his study looked at 3,600 patients with a median age of 34. And these were patients accrued from 2012 through 2017 by 154 colposcopists in 44 clinics in 12 states of the United States. So what Dr. Huh found was that the biopsy rate is lower than recommended. Only 1.5 biopsies per patient with a high-grade PAP and less than 1 biopsies on patients with low-grade PAP. Random biopsies, even though recommended, are rare, but ECC is very common across all ages. So the most common follow-up recommendation after colposcopy is 6 months. And colposcopic impression is usually not documented by physicians in the United States, and it has a really poor sensitivity to predict CIN2 regardless. So his overall takeaways were that guideline adherence is poor. There needs to be standardization, education, and a plan to move forward for how we can improve this. So clearly there's some deviation from the guidelines or guidance. And then what is the role of DYSIS in potentially improving this in the future? So the IMPROVE-COLPO study, or my portion of it, or my data showed, was from the first 9 clinics that completed recruitment, and it was published in 2017. We examined the DYSIS arm only, so the patients with the standard colposcopy followed by the DYSIS map, the prospective arm, and we measured the incremental detection with the biopsies after the standard biopsies. So what does it add to add the DYSIS map? The clinics were in 4 different states, as you can see. There were almost 900 patients, 881 patients, and 26 providers performed the colposcopies. And data came from patients that had ascus pap smear, low grade, high grade, AGUS. All comers were added in as long as they qualified for colposcopy. So for the patients themselves in my portion of the study, the median age was 33. Most of them were privately insured, but you can see over on the right side, there were about 2% of patients that had Medicare, and about 6% that had Medicaid, and about 1% that were uninsured. Most of the patients were low-grade cytology referrals, which is typical for practice as well in general gynecology. So about 88% were low grade and about 13% were high grade. And racial distribution was pretty typical. The majority of the patients were Caucasian, about 60%, and then Black and African American as well as Hispanic patients made up about 17%, and Asians about 5%, with the remaining other nationalities. So this is a little busy, but it's kind of summarizes the data from the IMPROVE-COLPO study DYSIS arm. So there were 887 patients that were enrolled. There were 6 patients excluded because of age, previous hysterectomy, or improper inadequate referral, which left 881 total patients that received both standard colposcopy and DYSIS mapping. Once they had their standard colposcopy, if we go to that middle portion, the middle red box there, of 372 patients, the colposcopist did not recommend any biopsy. 509 patients did have a biopsy, which was labeled as standard. And out of these 509, 78 had CIN2+, and 431 had less than CIN2+. Down at the bottom, after adding the DYSIS map, the patients that had CIN2+, we found an additional 17 patients with CIN2+. The patients with less than CIN2+, we found an additional 12 patients that did have CIN2 or greater. And in the patients who the colposcopist recommended no biopsy based on standard colposcopy, an additional 22 patients were found that had high-grade dysplasia CIN2+. So this shows how the DYSIS mapping works on a patient, and we have 2 examples of this. So this is before acetic acid application on a 33-year-old Caucasian lady who was referred for ascus and HPV positive. So once we add the acetic acid, we can see what happens over time. And you can see there's some aceto-white changes, particularly on the anterior and posterior lips, as well as a little vascularity on the posterior lip. And so the colposcopist would then decide what's your impression, normal, low grade, or high grade, and they would mark where they would typically do a biopsy. After 2 minutes, you can reveal the DYSIS map, which will be the next portion, and it's kind of like a weather map, so it shows you where the potential areas of concern would be. On this image, there's a number 1, a 2, and a 3. The 1 and the 2 are the standard biopsies, so that's where the colposcopist said, I'm concerned about these areas, I want to take a biopsy. And then the number 3 is the DYSIS biopsy based on this map. So you can see 1 and 2 both revealed CIN1, on histology versus the DYSIS mapping biopsy showed CIN2. So this is another patient with a little larger area that we can see. She's 36, same histology, ASCUS and HPV, or same cytology, ASCUS and HPV. And then we add our acetic acid, and we can see some aceto-white areas and some mosaicism. And you can decide for yourself where you would do biopsies on this patient and your impression, normal, low grade, or high grade. And then we add on the DYSIS map, and that shows us the same information that it did before. And now we can see where the biopsies were performed. So if you go back to the previous picture, Brent, we can see what things look like and where the biopsies based on standard colposcopy. And then we add our map on, and we get biopsies 1 and 2 were from standard colposcopy showing CIN2. And then biopsy 3 was added with the DYSIS map, and that revealed a even higher grade lesion, CIN3. So for disease detection, again, the standard biopsies with our basic colposcope, 78% patients had CIN2 plus, and 30 patients had CIN3 plus. With the DYSIS map assisted biopsies, we found an additional 34 patients with CIN2 plus and 15 patients with CIN3 plus. So this is overall increased detection rate on the graph on the right shows 44% for CIN2 plus and 50% for CIN3 plus. So the benefit for our study was across all subgroups. All age groups showed a benefit with DYSIS mapping. The referral reason, if it was low grade, high grade, ASCUS, all showed benefit with the DYSIS mapping system, and also per number of biopsies. So it didn't seem that just taking more biopsies was improving our rate of detection. It seemed to have to do with the actual mapping process itself. So the increased detection was largest for patients greater than 30 years old, for patients with CIN3, which is important, and then for patients that only received one standard biopsy. So biopsies based on the DYSIS map detected patients with disease that would have otherwise been missed with standard colposcopy. So biopsy practice, about 75% of patients received a biopsy. So there were almost 2,000 total biopsies, and 800 of these were standard, and then 365 were DYSIS assisted, and there were 16 random biopsies performed. So for CIN2, the positive predictive value for standard biopsies was around 13%, and for DYSIS biopsies was 16%. So overall, the conclusions of this portion of the IMPROVE-COLPO study showed an incremental benefit. So biopsies that were based on the DYSIS map, again, helped to detect more CIN2 and 3, and significantly more. The biopsies based on the DYSIS map seemed to be better in finding the disease, and additional biopsies didn't compromise the performance, and results were consistent for all patient subgroups, which is important. And additional disease appears clinically important. It was high grade. And then the DYSIS clinical effectiveness was shown in a real-world setting, so in standard of care colposcopy as an adjunct to that, with use of the DYSIS mapping. So this is just a graphic about where we potentially can move to in the 2020s and beyond. We know overall that we're doing less colposcopy than we were doing 10, 20, or 30 years ago. So lesions potentially are harder to detect, especially now that more folks are receiving the HPV vaccine. We know that overall there's extended screening intervals because now we're doing PAPs at 3 to 5 years instead of yearly. And so overall, this has kind of decreased our colposcopy sensitivity. So now we're trying to develop ways to help colposcopists in the future to get the biggest bang for your buck. So we want to increase the number of hard to detect lesions. We want to consider changes in time. The nice thing about the DYSIS map is you can look back at their 6 month ago images or their year ago images or their 3 year ago images because they haven't seen you back as frequently. And then we can confidently diagnose undetected lesions and things that are harder for us to find. And so overall, the DYSIS mapping helped us increase our CIN2 plus detection by 44%. So this just shows the latest DYSIS mapping system, and it shows kind of the different aspects of it and how we can potentially share your exam notes with other providers, and you can capture images and video. So it's helpful in looking back as well as forward for patients. So again, the color-coded DYSIS map quantifies where potential disease may be. It provides enhanced documentation so that we can decide better with changes over time on the patient's cervix, and then again, better detection and diagnosis.
So, Dr. DeNardis, that was terrific. Thank you very much for sharing with us all of the details of the trial and the publication. Very insightful. We do, I'll leave this slide up for folks. This is just our regulatory disclaimer, but you did a thorough job covering this throughout the presentation. We do have a few questions that I'd like to ask. The first is, based on your experience, how is the adoption process going from, standard colposcopy to the DYSIS Smart Colposcopy? How would you answer that?
It's pretty easy to adopt it. You're using your same colposcopy skills. The speculum is a little different because it attaches to the machine, so it probably takes 2, 3, 4 patients to get used to utilizing the system itself. But overall, it's pretty easy to adopt into practice.
Okay. Can DYSIS be connected into your EMR system?
As far as I know, the vast majority of EMRs can interface with DYSIS, so you can add pictures and videos if you choose to patient records and potentially share those with other providers.
Yeah, and I can confirm, yeah, you're absolutely correct in that. And then another one here on the use of Lugol's. So can they still use Lugol's with DYSIS?
So you can. You just want to be sure you apply the Lugol's after you do your DYSIS mapping, so it doesn't affect the spectral imaging at all. But absolutely, after you're done with your first colposcopy and then your DYSIS mapping, you can definitely add Lugol's and continue the colposcopy from there.
Perfect. And I just confirmed that was it for the questions. No more came in. And so with that, audience, thank you all for joining. Dr. DeNardis, thank you again for the wonderful presentation. With that, we'll wrap. Thank you again, and have a wonderful evening.